Thank you, Catherine, and thank you, Carey Institute, and thank all of you for being here tonight. Obviously, this is a topic that's very timely and relevant for all of us, but I just want to give you a little bit of background to how we got to this evening. I also want to give a shout out to Senator Serino's office, who has worked, Carly, where are you? Carly over here, who has worked with us on a number of the bills that we have passed and is also an advocate in our region for tick-borne diseases and Lyme. So amazingly, when my office launched our hashtag Get Ticked Off campaign earlier this year, no one had used that phrase before. I mean, it seemed pretty straightforward. If you really wanted to get people's attention, you get ticked off. And this was something that we, that we decided we were going to do as a social media campaign, that we were going to use the hashtag on Twitter and Facebook and launch a Facebook page and use it as an opportunity to spread information, to increase awareness, to educate, and to get people behind the kinds of changes that we need to make happen. And it's been great. It's been great fun because we've built this network of advocates for research and policy and funding for Lyme and tick-borne diseases across the country. There are some incredible foundations that are doing work on the West Coast and in the Rocky Mountains and are funding young people who are struggling with this disease and helping give grants to them and their families for both for treatment, but also just to cover other parts of their lives, because families, as you probably many of you here know, can really be drained financially from the costs related to this. So this campaign has been so successful that I would argue that earlier in the last couple of weeks, when the governor of New York actually launched his own tick-borne disease control plan, I would say it was in part a result of the pressure from people like you and others who continue to use this hashtag Get Ticked Off and continue to reach out to policy leaders across the state and across the country. And he really did move forward to make New York, which had been pretty lackadaisical, I would say, in what they were doing, to have much more of a game plan and really on his radar screen. Now, of course, it remains to be seen exactly what gets funded and what happens, but so far he did develop an eco-friendly tick control treatment for parkland in the Hudson Valley, the Capital Region, and the Southern Tier, and expanded the use, which you'll hear more about, of the 4-poster ticticide deer treatment feeding stations. He's introduced other policies to expand education and outreach to hunters and hikers. He did eclipse my legislation to put tick warning signs in state lands and parks, and we're hoping that we will still pass our bill, which is being worked on right now, in order to make sure, because when the governor does something, it's a regulation, he can do it, it's an executive order, but it isn't in statute. So if he leaves, or if another governor is elected, that can be, as we're seeing at the federal level, things like that can be reversed and are completely gone. So it's really important that when there are policies that we want to see happen, we make sure that they're in statute through legislation. We also have seen him follow the lead of the federal government and introduce his own New York State working group, which will meet next week for the first time on June 19th, and our office has been invited to be part of that, and I'm looking forward to attending that. I think we all are kind of aware of the fact that Lyme disease is, I would say more than arguably, the first public health epidemic of climate change, and it's plaguing hundreds of thousands of people each year. And a lot of this change has been as the result of global temperatures rising and ticks becoming more active longer and earlier before people are prepared. May has been traditionally Lyme and tick-borne disease awareness month. Ticks are out way before that. Once it stops being freezing, ticks are out, and I think we really need to be keeping up with that kind of change, and and not sort of fall prey to, well, this is the way we've always framed it, so it's okay to keep framing it that way. Since the 1990s, the number of Lyme disease cases has doubled, and in that same period, the number of counties identified as high risk have increased by more than 320%. And I'm sure almost everyone in this room, because you're here tonight, either has been affected by Lyme and tick-borne disease or knows someone who has seriously, and so you're not surprised that New York is ranked third among the highest of states in the country with Lyme and tick-borne disease, and Columbia and Dutchess County, the two counties that I represent, have among the highest rates in the countries as well. Just yesterday, I think it was, the Columbia County Health Department confirmed a case of Powassan in Columbia County. Today, there was another vector-borne disease identified in, what's it called, Miyamoto, in ticks in the capital region. So, I mean, things are happening pretty fast around here. There's growing evidence that the loss of biodiversity because of habitat fragmentation and overexploitation of resources as well as invasive species are part of this. And I would argue that even in our local towns and planning boards, that we need to be sure that people are more aware of the kind of planning that's done in our communities that breaks down this habitat fragmentation that, that makes the predators of white-footed mice, really makes it difficult for them to survive and destroys the habitats that, that lead to their free travel around the region. The federal government, as I said, launched as a result of the 21st Century Cures Act in 2016, and this was a legislation that was signed by President Obama, launched a tick-borne disease working group, which has met a number of times and has really made the federal government, because the CDC has been appallingly lacking in accurate information. Even the commissioner in New York State has said that basically CDC information is probably 10 times lower than it should be. And so it's great that the federal government is finally stepping up to this. I hope that we will not be disappointed with the results of the working group, which will be providing Congress with their recommendations on research gaps by the end of this year. Our office, as I suggested, with working on several of them with Senator Serino's office, have introduced and passed a number of bills, including one, and this was with Senator Hannan, which prohibits the investigation of any claim of medical professional misconduct based solely on treatment that is not universally adapted by the medical profession. So we, in this case, are focusing very much on the treatment protocols and making sure that patients have access to the very best treatments and the treatments that work for them. We also have several bills related, that are trying to inform and educate. And right now we're also working on a bill to, to get insurance coverage and make sure that that treatment protocols are covered by insurance companies. And this has been a bit of a dance between the Senate and the Assembly in trying to come up with language that creates the same as legislation that we can then send to the governor's office. So that's just a little bit of background, and that is why we are so committed to making sure that our region has all the resources and that New York State has the information and the resources to be dealing with what is truly a public health crisis and doesn't get the recognition and the awareness. I mean, I think we have seen the kinds of resources and the billions of dollars that go into such things like Zika research, which impact maybe 1,000 people, and the hundreds of thousands of people that are dealing with Lyme and tick-borne disease are left with a small $30 million allocation and funding in the federal government. So it's very important that we continue, and we have a great panel here who will continue to educate you and enlighten you on things that are being done in their areas of expertise. But it's very important that we continue the advocacy and put pressure at the federal as well as the state level to make sure that that these diseases and the treatment and the struggles that so many families are going through are on the radar screen for everybody who's who's in our state. And it still alarms me when I make presentations to or speak on the floor in the Assembly to have colleagues that say, oh, well, that's not an issue in my district because, and I had this literally from a fellow who represents Chautauqua County, and he said, there's only 2 or 4 reported cases in my county, and I said, that's because they're totally underreported. It's not because it's not existing there. And it's, and this is a legislator who's in a leadership position who totally didn't understand the full implications of what was going on in his own community. So without further ado, I'm going to introduce our speakers. And did you all want to come up at once, and I'll introduce you, or what do you want to?
If we sit up there, we won't be able to see.
Oh, got it. Okay, so I'm going to introduce our first speaker then, and that is Dr. Alison Kaufman, who is a public health advisor in the Communicable Disease Control Division of the Dutchess County Department of Behavioral and Community Health. In this capacity, she leads county disease surveillance and public health education efforts related to zoonotic and arthropod-borne diseases. Before transitioning to a career in public health, Dr. Kaufman spent 13 years as a practicing horse veterinarian. She holds a doctorate in veterinary medicine from Cornell University and a master's degree in public health through the University of Iowa. Kaufman is a longtime Hudson Valley resident, and we're very pleased to have her with us today.
So we'll see if we got our technology working. Yeah, looks good. Okay. So thank you so much for having me here tonight. I just wanted to start by saying that I'm a really big advocate for a concept called One Health. And One Health recognizes that the health of people, animals, and the environment are all inextricably interconnected, and that if we want to tackle really complex problems like tick-borne disease, it really requires an interdisciplinary approach. And so a forum like we have here tonight, where we have a physician, an ecologist, and a public health professional all speaking to you in one venue, is a prime example of One Health in action. So I'm just really grateful to the Carey Institute and to Didi Barrett for inviting me to speak to you guys tonight and talk to you a little bit about the role of the local health department in tick-borne disease. All right, so I'd like to start with this basic framework for how local health departments address health problems in general. I know, I love that cartoon. See, that's great. Everybody starts off with a chuckle, so that's good. So essentially what this is a continuous cycle of assessing the health problem, sharing what we learn with our stakeholders and community partners in the community, and then working with them to develop interventions that best serve our public, our residents, and then we implement these programs, events, campaigns, outreach, et cetera. And getting back to our cartoon, the idea is that we want to have things in place that prevent silliness, like what we see in the cartoon, okay? So above and beyond the basic framework that I showed you on the first slide, New York State Department of Health requires that all counties, including Dutchess County, develop and submit a Community Health Improvement Plan, or a CHIP for short. And what a CHIP is a long-term systematic effort to address public health problems based on the results of community health assessment activities. So all counties are required to submit this plan, and we were told that we needed to select at least 2 focus areas. In Dutchess County, we tend to be overachievers, and so we chose 3. And one of those 3 was tick-borne disease prevention. And there are 3 strategies on tick-borne disease prevention within that plan, and we'll talk about them individually as we go through this little presentation. All right, so the first step in this cycle is assessing the problem. So we'll start by taking a look at how we assess tick-borne disease in Dutchess County. And we'll start off with just a little bit of Q&A. And it looks like my animations are working, so that's good. So the first question is, what assessment activities does DBCH? We have a very long name, so that's what my department will be from here on out, is our initials, DBCH. So what assessment activities do we do to understand the burden of tick-borne disease in Dutchess County? And the answer to that question is that we do case-based human disease surveillance, and we conduct periodic population surveys. So a little bit about what those 2 things are. Case-based surveillance means that we count the number of cases of human disease, and tick-borne diseases are included in about 80 some odd infectious diseases that labs and physicians and healthcare providers are required to report to public health, essentially, so that we can count them. So we receive these reports, and in the summer, we receive a whole lot of tick-borne disease reports, so I'll stop being out on the circuit talking to people and be stuck in the office investigating all these reports. And And after we investigate them, we report our findings up to the New York State Department of Health, and they in turn report their findings to the CDC. And in this way, the data that we collect here in Dutchess County contributes to our overall understanding of the patterns of disease. We do population surveys for a slightly different reason, to collect different types of information. So these surveys are where we find out the concerns, the attitudes, the knowledge base of our residents, how they prefer to receive their information, and things like this. And then we use the results of these population surveys to inform our health promotion and disease prevention efforts in the community. So our second question is, so what findings provided the rationale for making tick-borne disease a CHIP priority? And the summary answer to that question is that human disease surveillance shows that we have disproportionately high rates of disease, and population surveys show that the vast majority of our residents consider tick-borne disease to be a very serious health concern in our area. So I tend to use this national map of reported cases of Lyme disease from the CDC in a lot of talks because it provides a good visual for why tick-borne disease is a priority in Dutchess County. So what the map shows is the distribution pattern of Lyme disease in the United States, where blue dots represent reported cases of disease, and they are clearly concentrated. Oh, I forgot I have a pointer. So they are clearly concentrated in the northeastern region of the United States, and you can see here in Dutchess County, the map turns dark blue, and what that's indicating is that we have a very high density of cases. So then if we drop down lower to dig a little bit more deeply, on the slide, we can see that the three tick-borne diseases that we see most commonly in Dutchess County and in New York State as a whole, Lyme disease, babesiosis, and anaplasmosis, are all endemic in the Hudson Valley, and in fact, the Hudson Valley is bearing the brunt of the burden of these diseases because our rates are very much higher than what we see in New York State as a whole. And we know that the geographic distribution, so the maps, if we were to do a map like this for anaplasmosis and babesiosis, it would look really very similar to Lyme disease because these diseases are carried by the same tick, and so they follow a very similar distribution pattern. And these incidence rates that we see for Dutchess County are about 2 to 5 times higher on average than the New York State average. Go forward. All right, so now we're going to take a quick look at each one of these diseases individually. We'll start with Lyme disease. And so what you see at the top is a graph that shows incidence rates per 100,000 population over time from 2010 to 2017. And then at the bottom, we have case counts for the same years. So what this graph is telling us is that the trend over the time is that we have consistently above average incidence rates for disease, and then we have some peaks and valleys. And those peaks and valleys happen because of a complicated interaction of a variety of different ecological factors, and I have a feeling that someone else on this panel will probably be getting into that in more detail as we go through. So just a couple of things to note on this slide. When you see case counts for Lyme disease reported from Dutchess County and a number of other highly endemic counties in New York State, as well as New York State as a whole, they're reported as estimated numbers, and that's because we do something called sentinel surveillance. And that's something we can get back to in the question and answer portion if anybody has some questions about how we do that. And then the other thing that I just need you to note is that there is an asterisk by the 2017 numbers, and that is because they're still preliminary at this point. New York State hasn't released those officially, so it's possible they could shift just slightly. All right, so this slide has the same figures as the previous slide except for anaplasmosis. And so what we see here is that anaplasmosis rates have increased in the county by over 60% since 2010. And this is very similar to what's going on if we look at the numbers in the state as a whole, that anaplasmosis is rising in that fashion. And then we go on and we look at the same thing for babesiosis. And so what we see, again, is consistently high rates of disease, but with a lot more peaks and valleys and year-to-year variation, with a really impressive spike in 2017. Yeah, you hadn't seen that yet, had you? I was waiting to see that too. So again, it's really important that we follow these trends over time, because what that will allow us to do is to, make some hypotheses about, well, is this year going to be an outlier? Or is this something that we're going to be experiencing as a trend? Or are our levels going to stay high like this? All right, so before I move away from surveillance, I just wanted to mention quickly that one of the 3 CHIP strategies that I alluded to earlier involves improving the validity of our surveillance data. This is something that pertains a little bit to what Didi was mentioning, that there are issues in infectious disease surveillance that lead to underreporting, and that's been highly documented for Lyme disease. There are a number of causes behind this. So one of the identified reasons for underreporting of disease is that there are cases of Lyme disease that can be diagnosed in the doctor's office just on the basis of a clinical exam, and that's the characteristic erythema migrans rash. So in most cases, when we get a report of infectious disease, it comes to us because there's been a lab positive, and that kind of comes to us automatically, and then that triggers us to start an investigation, as I'm sure poor Dr. Liegner is very aware of, because he gets lots of these requests for more information from us. But in the case of an EM diagnosis, there is no lab report, and so we won't know about that case unless a doctor takes the time to, on their own, report this to us. And so what this figure shows is that over time, from 1997 to 2015, the percentage of cases that we are seeing diagnosed with an EM rash has really fallen off precipitously. So what we have done is we've entered into a pilot study with our Regional Health Information Exchange organization, that's HealthLink New York, in which we are utilizing the electronic medical record data in their system to try to detect cases that are diagnosed in this manner, and then contributing them into the surveillance data, with the goal being that we want our Lyme disease case numbers to be more representative of the true burden of disease. And those will be included in the 2018 surveillance data. All right, so then to move into some survey data. So this is a snapshot from a survey that we did of, phone survey that we did of 600 Dutchess County residents in late 2015 into early 2016. And what we found, and this is a very big survey, so this is just one snapshot, but one of the things that we found was a disparity in concern over tick-borne disease versus knowledge. So more than 90% of our survey respondents consider Lyme disease to be a serious problem in Dutchess County, but only a third of the respondents assess their knowledge as knowing a lot about Lyme disease. So this is important for us because we can take data like this and we can use this as a rationale for why it is so important for us to continue to be able to get out and give our residents the information that they need to know, so that we don't have this disparity between a problem that they're concerned about and how much they feel that they know about it. So in addition to asking people how much they think they know about something, we also quiz them a little bit. And so what we see here, these are specific questions related to Lyme and tick-borne disease. And what we can do with this is that we can look at the specific things that people are scoring poorly on, like down here, like the appearance of the rash associated with Lyme disease, and the months when we have the highest numbers of cases that are the riskiest months. And we can say, okay, so this is where we know that people have less knowledge, and this is how we can decide what to emphasize in our prevention messaging. So the next step in the cycle is engaging our community partners. And in tick-borne disease prevention, these efforts have been solidified by the formation of a county work group. So the formation of this work group was also included as one of our 3 strategies in our CHIP. And it was created to be a structural framework for countywide prevention activities. So it started in February of 2017, and it's continued to expand to include representatives from partner organizations across sectors. And the benefits of this group are many. Some of them include that it's a vehicle for my department, as well as New York State Department of Health and our other partners, to disseminate this assessment data that we take so much time recording, so that it can be put into practice in our community. It's also a place where we can learn from each other and learn about best practices in prevention and share new developments in research, as well as promote each other's prevention programs and otherwise network to get new opportunities to get into new aspects of the community. So then the final step in the cycle, but remember this is a cycle, so everything is always going on at the same time, is that we promote health and prevent disease. And this is also a CHIP strategy. And the idea is that we want to promote the knowledge of effective tick-borne disease prevention strategies, and we do put an emphasis on high-risk and underserved communities. And I realized, because I'm worried about finishing in 15 minutes, that I neglected to mention, so these are my kids, right? It's always nice to look at your kids when you're doing a big nervous presentation in front of a lot of people. So what you can see in the foreground, this is Tick Check Harry. So he's a teaching tool that we use. We've glued poppy seeds and sesame seeds on him to teach kids how to look for the size of things, the size of ticks, and find them on furry animals. But in the foreground, we have one of the Dutchess County tick removal kits that you guys all received tonight when you walked in. And so these tick removal kits are a really great example of a collaboration that's come out of that work group that I mentioned on the last slide. So they were funded by one of our partner organizations, HealthQuest. My department purchased all the components. We worked with our MRC volunteers in one crazy long work day to put all these things together into 5,000 kits. And now my department, as well as our partners, utilize them in all the outreach events that they do, and we push them out to venues like camps and other places, and the parks and places where they need them. And this has really been, something great that's come out of that collaboration. So moving on to what I was supposed to talk about on this slide, is that, so in public health, we're always operating in a resource-limited environment. It's always been that way. It always will be that way. And what that means is that we have to be very strategic in how we do things. And so up here, we see some of the strategies for how we decide how are we going to take on this daunting task of health promotion and disease prevention on the subject of tick-borne disease. So number one is we target our efforts to high-risk and underserved communities. When I say high risk, I mean people with occupational exposure, so people that work out in the parks or are camp counselors, whatnot. People that have recreational exposure, like hunters, hikers, etc. Children, because we know that they have the highest rates of Lyme disease. Senior citizens, because we know that they have the highest rates of anaplasmosis and babesiosis, etc. And then when we say underserved communities, that's an example of how we use our survey data. So we look at that survey data and we look at the demographics and we see where are the gaps in knowledge. And then those are the people that we know that we need to seek out for more educational programs. We also use multiple modalities because we know that people learn in different ways and have access to different levels of technology. So we do print, we work with the papers, we do news releases. We have a website that has narrative information. It has a frequently asked questions document that Rick and I worked on together. And it also links out to a number of video elements. We have a phone line that we use, and we still do a lot of in-person events as well, both educational seminars and also attending community events where we sit tables and talk to people individually, give out literature. Then we seek out opportunities to do train the trainers. And so what that means is that when we're booking gigs for me to go out and talk to people, I look for places where the folks that I'm going to be talking to are in a position to further disseminate that information. And so that means groups of school nurses, camp counselors. When I go and I talk to the folks that work at the parks, I remind them that they're ambassadors to their guests that come into the parks. Who else have we done? MRC volunteers, child care providers, things like that. And that carries over into our efforts within our own department. So we are trying to integrate these efforts into the different divisions within my own department. So for example, the nurses that work in early intervention and in our maternal child health programs have all had training in best practices for tick-borne disease prevention. And the tick kits that you got, as well as literature, is included in the folders that go out to all the families that they serve as well. Lastly, we try to leverage our partners' assets. So we know that Didi and Carey Institute can fill a room. So yeah, we want to come out and talk to you guys tonight. And furthermore, we know that HealthQuest has a great social media presence, so we work with them to work on their prevention messages as well. And there's lots more examples of that. I probably have exceeded my time, so it's good that I'm on my last slide. I just want to thank you so much for listening to me tonight and to show you. So this is our tick-borne disease information line. If you're in this room, you're probably more educated than what's on this line. This is the basics. There's much more information on our website, both our in-house information. We also link out to
Must be another way to do this. Introduce our next speaker, who is Dr. Kenneth Liegner, who is a board-certified internist with training in pathology and critical care medicine, practicing in Pawling, New York, which, as you know, is in the southern end of Dutchess County. He's been actively involved in diagnosis and treatment of Lyme diseases and related disorders since 1988. Ken has authored In the Crucible of Chronic Lyme Disease, Collected Writings and Associated Materials, a history of the struggle to characterize the nature of Lyme disease in the late 20th and early 21st century. He's on the staff of Northern Westchester Hospital Center in Mount Kisco, New York, and in the Sharon Hospital in Sharon, Connecticut. So please welcome Dr. Kenneth Liegner.
Thank you so much, Didi. It's a great pleasure to be here. And Didi has had such wonderful leadership, not only in the tick-borne diseases area, but in other issues in Dutchess County. And it's also great to be here at the Carey, which is one of the world's leading ecology institutes. And they've done fabulous work. Rick is doing great work, has done great work, and is continuing to do great work and really clarify the complex ecology of Lyme disease. Okay, so Lyme disease is what's called a zoonosis, just a fancy way of saying a disease that exists in nature, that's transmissible to man. It has a very complex ecology, and I'm not going to go too much into the details of it. This is what I call PERP1, adult female deer tick. Some of these photographs were provided to me kindly by Derlin Fish, who's an entomologist. And this is an adult female deer tick in the palm of the hand, just to give you an idea. These are pretty small. They're about maybe 2/3 the size of a cantaloupe seed, maybe. And this is a feeding nymphal deer tick. It's actually partly engorged, so when they're not engorged, they're even smaller. So they really are about the size of a poppy seed, and they're very easy to miss. That's with next to a human fingernail. And some bad news, there's a stage that's even smaller than this called the larva. People used to not worry about the larva too much because most of the larvae are not infected, but it's turned out in recent years we've learned that there's another Borrelia in the ticks that's not Lyme. It's what's called a relapsing fever Borrelia, or Borrelia miyamotoi, and that is transovarially passed. And so even the larvae, which are almost impossible to see, and also the most numerous in nature, has the potential of transmitting Borrelia miyamotoi, which has been recognized now to be a human pathogen. This is the business end of a deer tick, a scanning electron micrograph, and I think all of you looking at this can appreciate why it's so extremely difficult to remove an embedded tick, right? And if you think about it, it's really an amazing feat of animal engineering. When the tick has fed to repletion, what it does when it's ready is it secretes enzymes that basically digest the skin, so it just kind of plops out of the skin when it's fed fully. That's what's called the hypostome, that kind of sword-like image. And the other undersurface of of the hypostome is over here. And you'll notice over here, these sharp teeth-like things are called chelicera. And when the tick is feeding it, it just kind of slices through the skin like, you know, Vorpal sword Snicker snack, you know, from the, and it also secretes local anesthetic, and also secretes enzymes that are anticoagulants that help the blood pool, and furthermore, it secretes substances that impair the immune response, so that whatever pathogens are in the tick are more able to disseminate in the host. This is a scanning EM of a nymphal deer tick feeding on rabbit skin. So that's perp 1. This is perp 2. This is a electron micrograph of a Borrelia from the Rocky Mountain lab out in Montana. And I just want to point out to you that, so this is what everybody's familiar with, but I want to point out that these are membranous blebs which are shed off of the surface of the Borrelia, and it's not just bland membrane, but when those blebs bud off, they actually contain within them genomic DNA. So, and this is part of the basic biology of Borrelia, and if I have time, I'll talk a little bit about that a little bit later. This is a scanning, laser confocal scanning microscopy work that was done by Mark Klempner and colleagues. And what this demonstrates with laser microscopy, you can go like micron by micron through cells. And what this study demonstrated is that this is a Borrelia, and using this technology, they were able to demonstrate that the Borrelia is not just outside of the cell, but actually inside the cell. And it's been known for many years that intracellular infections can be very difficult to treat and cure. This is from a study in Europe of a woman who had Lyme disease, had gotten treated, including intravenous antibiotics, and then sometime later had inflammation of one of her tendons of her finger. And they had a great research team. They did surgery, and they subjected the tissues to careful study. And what they demonstrated is these are collagen fibers, which make up the dense connective tissue, and nestled right in between the collagen fibers is a spirochete. So spirochetes seem to, Lyme Borrelia seem to really like dense connective tissues. And, sorry, oops, gotta go back. Let's see. Yeah, and right here, what you see is these are Borrelia in the process of invaginating the fibroblasts and actually going inside the cell. You know, this isn't a living patient. This is not in the test tube. So, as I'm sure you're all aware, there are so-called classic, or what they call pathognomonic manifestations of Lyme disease that everybody should recognize, but shockingly sometimes, even with these classic manifestations, the diagnosis is not made. The Lyme rash or erythema migrans, drooping of the side of a face, inflammation of a joint, heart involvement, or frank meningitis. And of course, everybody's happy when this happens in a so-called known Lyme endemic area. And then, but not, aside from that, there's many non-specific symptoms that people have that could easily be seen in other conditions, you know, very non-specific. It could be viral-like. There could be all kinds of symptoms that are really non-specific. And you know, you could easily miss the diagnosis of Lyme just looking at these symptoms, but often these symptoms are very prominent and very debilitating. And then there's a wide and expanding range of multi-system manifestations. And any system in the body, any tissue in the body can be affected by Lyme disease. And also, you know, this is a relatively new infectious disease. It's only been really fully defined over about the past 40 years. And there's many new manifestations that they're not even in the textbooks yet. So we have to really keep an open mind. I'm fond of saying that it took medical science a good 500 years to get a good understanding of syphilis, which is another spirochetal infection. So we're only 40 years into Lyme disease. So we have to be humble before this disease. There's a lot that we don't know. And also there can be atypical manifestations where there's no known rash, no known tick attachment, and also happening in areas that are not yet fully recognized to be Lyme endemic. You know, you mentioned Chautauqua County, and apparently a lot of physicians up there don't realize that it's endemic, but actually I think every county in the state is considered endemic now. And then also there are cases where the tests aren't positive for one reason or another, and that makes it difficult. Or you have tests that are not fully diagnostic. and sometimes you have one-of-a-kind manifestations that haven't been seen before. One of the early patients that came to me had what's called a cerebellar syndrome, where she couldn't maintain her balance, and she had a very scanning kind of speech. At that time, that had not even been reported in the literature. I remember it was kind of frightening to see this case. But then later, other cases have been reported. So if you're on the front lines, you may be seeing things that nobody else has seen before. And often, most difficult for the patient, but also difficult for the physician, the patients can be in this state of limbo, where you really, if you're honest, you really don't know what they have, and that can be very anguishing for the patient. I found that patients can deal with almost anything. They can deal with the diagnosis of cancer once they know what it is, but when they don't know what it is, it can be very, very difficult. Lyme disease has been called the new great imitator by Andy Packner, syphilis being the original great imitator. So we get into the controversy over chronic Lyme disease, and that boils down to competing conceptualizations of the illness. Can the Lyme organism persist after application of standard courses of antibiotics? Just how reliable are the standard tests in diagnosing Lyme disease at different stages of illness? And in the absence of a highly reliable, highly reproducible, direct detection method that everybody can agree on, controversy thrives. On the one hand, you have this dogma. Lyme disease is difficult to acquire, easy to diagnose, readily cured with a short course of antibiotics, and if the patient has symptoms following treatment, either the initial diagnosis was wrong, or the patient now has post-treatment Lyme disease syndrome, because of course, there is no such thing as chronic Lyme disease. On the other hand, you have the other position that Lyme can be difficult to diagnose. The tests are not always reliable. When we treat, we cannot be assured that the infectious agent is invariably eradicated with bacteriologic cure. Some individuals relapse following recommended treatment regimens, and the agent of Lyme disease is highly complex, has many stratagems to evade destruction by antimicrobial agents and the immune system. And some cases of Lyme disease can be extraordinarily difficult, not only to diagnose, but also to treat. The folks at the Rocky Mountain Lab who took that first picture that I showed you of the Lyme spirochete actually developed a test that was depending on detecting those blebs that are shed by the organism. And they published on it, and the problem with this particular method is it required electron microscopy. So it's very, very labor and resource intensive. I'm one of the few physicians who had the opportunity, because I was working at that time with people from CDC. They requested specimens from the patients I was caring for. And unbeknownst to me, they sent these on to the Rocky Mountain Lab, where the methods of detecting those blebs that were shed were used on specimens from my patients. So this is a grid that was created by Claude Garon at the Rocky Mountain Lab. And what it shows, RML is that method using electron microscopy to see these blebs that were shed. And the other columns are standard antibody tests. TQ stands for Tom Kwan, who's one of the folks at CDC Fort Collins. 3 different standard antibody tests. And he made a grid of the results. And the most outstanding thing to me about the finding was this column. And what this column showed, that out of the 51 specimens that were tested, 37 out of those 51 had positive results on the urine antigen capture, but negative on the standard test. So this suggested to me that there's a deeper reality to Lyme disease than that's being captured by the standard 2-tiered testing methods that are often recommended. And we did report that at a meeting in Arlington, Virginia in 1992. And those are my co-authors, Claude Garon and Dave Dorward from the Rocky Mountain Lab in Montana. And the conclusions were, the study results using this direct antigen detection method suggest seronegative Lyme disease is not rare and lend support to the hypothesis that B. burgdorferi can persist in the human host despite intensive antibiotic treatment. A lot of the patients in these who were studied were people who had already gotten very intensive and lengthy treatment. The problem with this method is it was not something that was easily transmitted to something that was suitable for high throughput commercial uses, so it kind of just sat on a shelf. As if Lyme disease itself weren't bad enough, you have all these other tick-borne co-infections, and I've just listed some of them. There's a couple different strains of babesiosis. There's ehrlichiosis and anaplasmosis, which are kind of Rocky Mountain spotted fever-like infections. And they can be quite serious, and people can get seriously, acutely ill, and can even die from them if they're not properly diagnosed and treated. There's many people feel that Bartonella, Hensley, can be tick-transmitted. Rocky Mountain spotted fever itself, which I don't think we've had too many cases in New York as far as I know. The deer tick virus and Powassan virus, which that can be transmitted after very short duration tick attachment within 15 minutes. Fortunately, it's not that common, but there's no treatment for it. Not everybody gets deathly ill, but some people can get very serious illness and can die from it or be left with permanent neurologic damage. In the Midwest, there's some other viruses that ticks transmit. As far as I know, they're not known to be transmitted by deer ticks. Heartland virus, which produces an illness very much like ehrlichiosis clinically, but it doesn't respond to antibiotics. The Bourbon virus, which is that's a county in Kansas where it was first detected. There's something called tick-borne encephalitis virus in Europe and Asia. And then Francisella or tularensis or tularemia is potentially tick-transmissible. There's the relapsing fever Borrelia. I mentioned Borrelia miyamotoi, which is found around here. And then, as we're learning, there may be many other as yet unrecognized bacterial, viral, and parasitic pathogens. And it seems as every month goes by, every year goes by, we're discovering more and more diseases that these ticks carry. So that's why it's important. Lyme is serious, but so are these other tick-borne diseases, and that's why control of ticks is so very, very important, because you control the ticks, you control all of these different diseases. I'm going to quickly go through some illustrative cases depending on the time I have. This is like the most beautiful, perfect erythema migrans rash you'd ever see. This is from one of my patients. He got treated with antibiotics early and did well. He had follow-up with me, and he was fine. As far as I know, he was cured. This is behind the knee, which is a very common place for this rash to occur. The next case, I'm not going to show it just yet, is a gentleman who was from where I used to practice in Armonk in Westchester County, and he developed severe lancinating facial pain that drove him to the ER at a major tertiary care hospital in my area. There, the doctors were convinced that he was just a drug addict. He was just involved in drug-seeking behavior. And actually, they called the Westchester County Police and bodily hauled him out of the ER. Okay? And then the next day, he developed this, a Bell's palsy. Okay? And had anybody bothered to examine him, they would have found the remnants of his erythema migrans rash. Anyway, he got treated. He did require some intravenous antibiotics, but he eventually got completely well. The next thing is from another patient of mine, a famous patient, Vicki Logan. I don't have time to go into great detail, but she was a pediatric ICU nurse who was sick for many years with a meningitis that nobody had been able to figure out what it was from. It's a long story. I can't really go into it. But suffice it to say, she was treated by me, including with intravenous antibiotics. And a year later, she asked to be, actually she begged for another spinal tap. And at that time, I tapped her, and I was working with the CDC. They provided me with culture media called Barbara Stoner Kelly 2 media. And at that time, I plunked a couple of cc's of spinal fluid into that culture media. And a few weeks later, I got a very excited call from the CDC in Fort Collins from Dave Dennis, letting me know that there were spirochetes growing in the spinal fluid, which were later shown to be B. burgdorferi. And that was Roy Campbell out there who positively identified it. And it's very unlikely that she got infected because she was wheelchair and housebound and didn't have any pets. So, and we did report this at the 5th International Congress on Lyme Borreliosis, and those are my collaborators at the time, including folks from the CDC. And our conclusion at that time was culture of this spinal fluid specimen in BSK2 yielded a strain of B. burgdorferi. Culture confirmed treatment failures have been previously reported for 3 Lyme neuroborreliosis cases in Europe. The present case apparently is the first of this type to be reported from the United States. This made the front page of the Science Times in 1993, and that's me at Vicky's bedside. There was a guest commentary on this, and I like the quotation, which is from Jean-Martin Charcot of the Salpêtrière. Disease is very old, and nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. There's a lot that's occurring at the present time that's very, very positive. There's a lot of philanthropic funding that's advancing scientific research. Some of these organizations, the Global Lyme Alliance, Bay Area Lyme, the Lyme Disease Association, the Stephen and Alexandra Cohen Foundation, who's helping to fund the work that is being done by the CARI, the National Science Foundation, and a number of others. And I also want to point out, you don't have to be a Bill Gates to support this research. Any of us can, and hopefully will, support the research that's being done. Mention was made of the Health and Human Services Tick-Borne Diseases Working Group. My former congressman, and probably of many of yours, Chris Gibson, was the one who actually incorporated this provision into the 21st Century Cures group. I just want to say there's wonderful, dedicated people who are really sacrificing to spend their time on the working group, and I think a couple of them are here. Jill Auerbach is here. Where's Jill? Jill, she's doing great work. And Rick, you're also on the, you're not, aren't you in one of the subcommittees or something? No, okay. Well, is there anyone else who's on the working group besides Jill? Okay. Anyway, it's a lot of time, a lot of dedication, and I think some very positive things are going to be coming out of that. Also, for many years, there's been tremendous denial of the problem of persistence and chronic Lyme. In the last 4 or 5 years, there are at least 4 academic groups that are really dedicating themselves to try to develop improved methods of treatment for Lyme disease, and they're already having success. Kim Lewis is at Northeastern University, Ying Zhang is at Johns Hopkins, Jay Rajadas is at Stanford, and Eva Shapi is at University of New Haven. So I am very, very confident we will have better methods of treatment, and not that long. I think we're going to have much better methods, maybe methods that can be truly definitive and curative. John Arcott's doing what he called a SLICE study at Johns Hopkins, which is very carefully following documented erythema migrans patients over time. Brian Fallon at Columbia University, their Tick-Borne Disease Research Center, and also they have an autopsy service where tissues from patients who died with Lyme disease are being carefully studied. And also, we're on the cusp of vastly improved methods of diagnosis, what's called next-generation sequencing, recombinant antigens, microarrays, where from a single drop of blood we'll be able to diagnose multiple tick-borne diseases. Also, there needs to be more focus on direct detection methods. There's a company called Series Nanoscience that has what's called a Lyme nanotrap, which is a urine antigen test, and that's beginning to be used, although it's not yet available in New York State. And the National Institutes of Standards and Technology has developed a method using liquid chromatography and mass spectrometry. And basically what they're doing, this is the correlate of the Rocky Mountain Lab antigen capture assay, which detects membranes in bodily fluids. And I believe that this could be, you know, the logical development of the Rocky Mountain Lab antigen capture assay, which could be not only qualitative, but even semi-quantitative, where you could have like an objective measure of like Borrelia load, analogous to what you have for HIV. Okay. And then efforts at prevention, of course, right here at the CARI Institute, the work that Rick Ostfeld and Felicia Kiesing are doing, and she's going to talk about that shortly. Kevin Estveld has developed a method called CRISPR that will make mice inhospitable to Borrelia. Valneva is coming out, was trialing a Lyme vaccine, and also, as mentioned, there's the USDA's 4-poster, which is, the idea of that is to try to decrease tick populations over broad geographic areas. Thank you all for your attention.
Thank you. And now for, you need to get in here. Well, now for a third perspective on Lyme and tick-borne disease, and our final speaker, after which we have a mic set up here, and we will invite our speakers to sit at the panel and then ask those of you who have questions for any of them or any of us to come and join us here, and we will get through as many of those as we possibly can. Dr. Richard Ostfeld is a disease ecologist and distinguished senior scientist at the Carey Institute of Ecosystem Studies, where we all are. He is internationally recognized as an authority on Lyme disease, and his work centers on protecting human health through environmental management. Ostfeld authored Lyme Disease, The Ecology of a Complex System, the first book to challenge the dogma that Lyme is closely tied to deer abundance, and instead approaches the study of human infectious disease as an ecological system. Rick holds a PhD from the University of California at Berkeley and a BA from the University of California at Santa Cruz. Rick Ostfeld.
I'm going to grab a drink of water. Thank you, Didi, and thank you, Catherine and Lori Quillen, the rest of my colleagues at the Carey Institute, and thank you all for coming out on a lovely evening to spend your time hearing about creepy crawlies and terrible diseases. So what I'm going to describe to you this evening is research in action. I'm going to tell you about a project that is in its midst. We're working very hard on this project. I have some results to show you, but the definitive results will have to wait a little while. But I hope I will pique your interest in staying tuned for those more definitive results later on. We're extremely clever, so we call this the TICK project. We're very creative, but that's less of a mouthful than what we're actually doing, which is right here. We're testing environmental interventions to prevent Lyme disease and other tick-borne diseases in our communities. So I'm going to give you a little bit of background. You've already gotten some from both Alison and Ken. This is more of a national perspective than a Dutchess County perspective on the statistics of cases of the three main black-legged tick-transmitted diseases. Lyme disease emerged in the United States in the late 70s and early 80s, and as you can see, it has inexorably increased almost every single year up to near the present. That actually has continued if I had more updated information from the CDC. The same is true of anaplasmosis, which emerged in the 90s and shows an even more rapid rate of increase, perhaps, than even Lyme does. These are data from New York State because babesiosis has only recently become a nationally notifiable disease. So the national statistics are not very valuable as of yet. All three of these are obviously dramatically increasing at the national level in number of cases. As has been discussed already by both previous speakers, especially Alison's excellent treatment, we know that there is underreporting represented by these statistics, and the CDC has made an effort to estimate how badly are we underreporting the number of cases per year, especially of Lyme disease. And the answer is we're only capturing about 10%. So in the case of Lyme disease, and this is probably roughly true for the other two main black-legged tick-transmitted diseases, we should multiply these statistics by 10. So instead of there being about 30,000 to 35,000 cases annually in the United States, there are between 300,000 and 350,000 new cases of Lyme every year in this country. As has been said, they're all three transmitted by the black-legged tick, formerly called the deer tick. And this is a slide showing how much the distribution of Lyme disease, the main one of these, has changed in the past 15 years or so. So this shows the distribution of Lyme disease cases in counties in the US back in 2001. And this shows what things looked like in 2013. So if you live locally, maybe you don't care about this because we're already right there in the darkest of the dark blue in the epicenter of Lyme disease in this country and in fact in the world. But if you live somewhere in northern or western New York or western Pennsylvania or northern Illinois, and Lyme disease has suddenly appeared in your backyard where it never occurred before, you care about this quite a bit. So what I've tried to convince you with those couple of quick slides is that we have a really difficult and intractable problem, and the previous speakers have addressed this as well. We have a situation in which Lyme disease and other tick-borne diseases are rapidly increasing in both their incidence, the number of cases, and in their geographic range. There are no vaccines available for any of these diseases. As Ken described very elegantly, diagnosis and treatment are highly problematic and extremely controversial and the source of a huge amount of energy, some of it, frankly, wasted energy that we spend fighting with each other. The estimated cost at a national level of Lyme disease alone, and this is only the healthcare cost, this is not psychological costs, it's not reduced property values, it's not reduced revenue from recreational things that we might buy if we felt safe going around and recreating in Lyme disease endemic areas. Healthcare costs alone are between $700 million and $1.3 billion a year. So it's costing our economy substantially. And the last point I'm making up here is that effective tick management is poorly developed. So issues with diagnosis and treatment would subside quite dramatically if we knew how to control ticks well enough that we prevented those cases from ever appearing, needing to be diagnosed and needing to be treated. This is a very difficult statement for me to make. Many strong, intelligent, hardworking scientists have been studying tick control, and indeed we know lots of ways to kill ticks out in the environment. There are lots of means of doing so with chemicals, with biological control agents, with physical agents that drive the ticks out and the like, but we have not yet figured out how to do so in a way that protects human health against tick-borne disease. That is largely because the trials, the studies that have been done to see what works to kill ticks have been done at a small spatial scale, usually a very small group of plots in the forest or a couple of backyards. There is a low level of replication. High levels of replication are required for rigorous science, and there's generally very poor control. So the designs are not strong. That is not because the scientists doing this work are lazy or stupid. It is because they're underfunded. There is very little research support to do this kind of work. There are a few exceptions to this small-scale poor replication and poor control, and I'm going to describe to you one of these right now. It was well replicated, done at a large spatial scale, and very well controlled, but it gave rise to crushingly disappointing results. And that was a study performed by a bunch of scientists led by Alison Hinckley at the CDC. They conducted their study over 2 years, 2 consecutive years. They used 3 states, one of which was New York State. In fact, their focal county was Dutchess County. Some of you may have participated in this study. They had over 2,700 households. It was a double-blind design, which means that neither the people living in these households that would get their households treated or their yards treated, nor the researchers collecting data in the field were aware of what treatment was being imposed on those households. It was randomized and it was placebo-controlled. So there was a placebo that was delivered but not known whether the placebo or the actual treatment was delivered to any particular property. The actual treatment was 1 annual springtime spray with bifenthrin, which is a synthetic pyrethroid that is known to kill ticks effectively and is one of the products of choice used by pest control operators here in the Northeast. The placebo control was spraying with water. And the researchers followed up on the effects of this bifenthrin spray or compared to the placebo control on abundance of ticks in these people's properties and on cases of tick-borne disease. What they found was that this spraying with bifenthrin resulted in a 63% reduction in the abundance of ticks that were crawling around in these people's property ready to grab a hold of the residents of those properties, potentially make them sick, but no other statistics showed any effect at all. So in essence, when they looked at ticks crawling on people, there was no difference between properties that had the acaricide and properties that had just water. When they looked at the number of ticks attached to people, again, there was no significant difference, not even close to a difference between the acaricide and placebo treatments. When they looked at self-reported illness, again, not even close to a significant difference. And verified illness by physicians, there was no difference at all between the two. Why? Well, we don't know. We don't know why, but we have some suspicions based on knowing the design of the study and a fair bit about the biology and medical aspects of tick-borne disease. One possibility is that a 63% reduction in tick abundance is not enough. That when you reduce them by 63%, there are still enough ticks crawling around in the environment that your probability of confronting one and getting sick from one is still reasonably high. And this might occur, there may be no difference if there's a nonlinear relationship between tick abundance in your yard and your probability of getting sick. So that you need to knock them down below some threshold, some unknown threshold of abundance in order to really serve a protective effect. That's one hypothesis. Another is that 2 years is too short, that these ticks can enter your property from elsewhere. They can do so at almost any time. That ticks generally, as far as I understand it, don't respect property boundaries and neither do the mice and chipmunks and deer and other creatures that move them around. And so 2 years is too short of a time to have a lasting impact on ticks on individual properties. And the last possibility is that treating individual yards is too restricted. One possible reason for that is, again, that the ticks on the hosts in particular are quite mobile. They can be imported into your property from elsewhere, and perhaps people spend time elsewhere in their neighborhood recreating, walking the dog, chasing balls, taking shortcuts to get to the bus, and so they may be exposed elsewhere besides only on their own property. The dogma is that the Lyme disease is what's called a peridomestic illness. You get it, you're exposed to it around your home, but the support for that dogma is not very strong, so maybe you get it elsewhere. The Tick project is designed to account for all three of these possibilities. So our design, which I'll describe in a bit more detail in a second, we use 2 tick-killing methods. Our study is a 5-year-long study, and we are treating not just individual yards, but entire neighborhoods, or many of the yards in an entire neighborhood. So our goal is to develop and test a safe, and by safe I mean safe for people, for pets, and for the environment, effective and affordable means of preventing tick-borne disease at the scale of whole neighborhoods. The 2 interventions are as follows. One of them you can't see, but I have this lovely picture of a forest floor in here because this is a species called Metarhizium bruneum that is a microscopic fungus that is a native to the northeastern part of the United States and elsewhere. It makes its living under the leaf litter in the soil, attacking and killing arthropods, bugs, including ticks. This is what ticks or tick eggs look like when they've been colonized by this fungus. It's a gray columnar style fungus, and that tick there on the right and these tick eggs that we hatched in my lab are dead because that fungus. Let's hear it for the fungus. There is a commercial product called MET52, which has isolated a particular strain. This is a naturally occurring strain. It is not selected for by scientists or genetically modified. It can be made into solution and sprayed in people's yards as you would spray a chemical insecticide, but it is not a chemical. It is a biological acaricide. We were concerned that MET52 might behave like the chemical sprays, like bifenthrin, and essentially every single chemical spray that kills ticks also kills lots of insects, indiscriminately, essentially, including honeybees and butterflies, spiders, which are more closely related to ticks and not insects. We were concerned that MET52 might do the same thing. A postdoc in my lab, Ilya Fishhoff, led a study to ask to what degree does MET52, this product, kill non-target arthropods, things that we don't want to be killing but could be susceptible. And without boring you with lots of data, I will simply give you the title of the paper that appeared last fall. It does not reduce non-target arthropods in a study that was carried out here on the grounds of the Carey Institute. And I can provide links to this paper. It's an open access paper to anyone who wishes. The second intervention is what's called a TCS, for Tick Control System bait box. So this is a small plastic box. This is from the website of the company that makes these. This is not to scale. That's kind of this Godzilla chipmunk. The boxes, the chipmunks are small enough to fit inside the box. So essentially there are two holes on either side of the box. Mice, chipmunks, and shrews are attracted to a bait reward on the inside of the box. To get to the bait, they have to brush by a tiny little wick that applies a minute drop of fipronil, which is the tick-killing substance that is in Frontline, the product that we put on our dogs and cats and have been doing for many decades by the tens of millions, hundreds of millions probably. So this is safe for vertebrate animals. It's a minute drop, and it kills fleas as well as ticks on these small mammal hosts. And so what we do, we have a mean of about 5.5 of these boxes per property. So why do you want to kill ticks on these small mammal hosts? That's because these small mammals actually feed a lot of the ticks that are out there in the environment. So you saw a couple of nice pictures showing you just how tiny these larval ticks are. Well, these are ticks on the ear of a free-ranging Millbrook mouse that was caught, I don't know, a couple hundred yards from here a few years ago. This is what a typical mouse in Dutchess County looks like in midsummer when these larvae are out. So if you can kill the ticks on a mouse and a chipmunk and a shrew, you will be killing a lot of the immature ticks that there are out in the environment, because those are 3 of the most important hosts. And moreover, these are the main hosts that infect the ticks with these tick-borne pathogens, the ones that make us sick. So without going into too much detail, these are data from my lab, summarized from several years of research. And basically, the bars indicate how many of the ticks feeding on these different species of hosts acquire infection with the Lyme disease spirochete. 92% of the ticks that feed on white-footed mice acquire a spirochete and become an infected nymph that's dangerous to you and me. For chipmunks and 2 species of shrew, the values are about 40 to 55% or so, and those are the main important purveyors of these tick-borne pathogens. The same is true of Anaplasma and Babesia, by the way. Mice, chipmunks, and shrews are the best reservoirs, not only for Lyme, but also for these other 2 tick-borne pathogens. And things like deer and opossums and skunks, that stands for ground-dwelling birds, not god birds. Those guys are poor reservoirs, so they do not infect very many of the ticks that feed on them at all. Okay, so just to summarize that, so we have 2 interventions. We have this MET52 fungus that kills ticks in the environment, but not non-target arthropods. And the bait boxes kill ticks on what we call the reservoir hosts that are responsible for serving as the host, feeding, and also infecting many of the ticks. Where are we doing the study? The study is being done in Dutchess County, and we worked with our colleagues at, I'm going to call you the Dutchess County Department of Health, because you were at the time, and I never remember whether behavioral or community comes first. They were the county health department when we got these data from them. We were able to create a risk map showing where the incidence of Lyme disease and other tick-borne diseases is highest, and we chose neighborhoods on the basis of where incidence rates are the highest. We had a few other criteria as well, but that was the main criterion for choosing where to deploy our interventions. This shows you what a typical neighborhood looks like from an aerial shot. It's a fairly discrete neighborhood, roughly 100 homes, fairly close together, fairly small lot sizes. Typically a quarter acre, a third of an acre, stuff like that. That is where there is a very high incidence of Lyme disease in our county and elsewhere. So here's the basic design. What we have 6 replicates, where the replicates are entire neighborhoods, okay? These are lots and lots of homes. That's a replicate. So we have 6 replicates that have real bait boxes and real fungus. Those are the lucky ones. These are selected at random. We have 6 replicates that have real bait boxes, but they have what I'm calling inactive fungus. Basically, that's a euphemism for water. That's the placebo control. We have 6 replicates that have inactive bait boxes, so these are real live bait boxes, but with no fipronil inside. But they do have the fungus, the real live fungus in the spray. And then we have 6 replicates that have inactive bait boxes and inactive fungus. So those are real controls. Those are controls for any possible placebo effect or any possible bias that might enter into the researcher's ideas, either explicitly or implicitly. And so this design allows us to use the gold standard of scientific research, where it's randomized, it's placebo-controlled, and it's double-blind. So we go out there and we deploy bait boxes, we spray MET52. What data do we collect? What are we after? What are the response variables, as we geeky scientists would say? What we do is we bother the people in our study every 2 weeks for 10 months of the year. We pick on them, and we send them either by text or email, or if they really need it, by phone, a questionnaire that consists of 2 questions. Have you or anyone in your household, including your dog or your cat, found a tick on your body or embedded in your skin? Second question, have you or anyone in your household been diagnosed with a case of tick-borne illness? If they say no, we leave them alone for 2 weeks and then ask them again. If they say yes, so that's self-reporting. If they say yes, we then ask them for permission to contact their healthcare provider to get a confirmation of that report. So we request access to that specific medical record. So people have informed consent. They're free to say no, and we don't bother them. Many of them do say yes, and we're trying to increase compliance. And in addition to that, we send these crack teams of people you might have seen walking around in white coveralls. There may be some in the room, maybe not. They wouldn't wear white coveralls to this event, I hope. We go out and collect ticks on these people's property by dragging a cloth on all the habitat elements, their lawn, their gardens, if they have woods nearby, etc., anything they'll let us. And we estimate tick abundance, and we also live trap the small mammals on their property and ask how many ticks are on those guys as well. So what we have found is that it took a tremendous effort, pretty much all of 2016, to recruit a sufficient sample into this study, which is not surprising given what we're asking of them. We're nosy people. We bother them every 2 weeks. We ask for their medical records. They are engaged in a long-term relationship with us, and some might not want to do that. Go figure. But we have between about 25% and over 40% of the properties in a given neighborhood who have agreed to participate in this onerous research project and engage with us as partners. When we send out those biweekly surveys, what kind of response do we get? Well, initially, it was a little lukewarm. About 55, maybe 60% of the survey questions, of the households actually responded to our questions. And we were a little worried about that, but then it went up, and it stayed at around 80%. So this is 4 out of 5 people responding to every survey they get every 2 weeks, almost year-round. And in fact, this chart ends here in 2017. In 2018, it's gone up. So we now have about more than 85% compliance with our biweekly surveys. You have a few statistics, by the numbers kind of thing. We have 951 participating households, about 2,300 people in those 900 plus households. Rover and Fluffy, we've got about 275 of those. We've completed over 17,000 of those biweekly surveys. We have sampled 518 properties for ticks, 264 properties for small mammals. We started our interventions in 2017, and our second round of 2018 interventions are ongoing as I speak. What are our expectations? We think it's likely, but we will test this hypothesis, that 2 interventions will be more powerful than 1, like the bifenthrin intervention. We think that the longer duration, we're spraying the fungus twice during the nymph season, which is right now. We have boxes, those bait boxes are out all season long, and both of those will be in effect for 4 consecutive years. We think that that will be more effective than 1 or 2 years with 1 intervention done once. We expect that the bait boxes will reduce infection prevalence in the ticks by killing the ticks that are most likely to acquire infection, the ones that are on the little mammals, as well as reducing the abundance of ticks. So that's a double whammy from 1 intervention. And we expect that treatments of neighborhoods will be more effective than single yards. We even expect that people living in these neighborhoods who've said, forget you, we don't want to participate in your study, they may actually derive a benefit if enough of their neighbors have their yards treated. So they're cheating the system, they may benefit, more power to them. The logistics, it's a 5-year study scheduled to end in 2021, right at the beginning of 2021. Last year was the first year that we did the interventions, because 2016 was the recruitment year. This is the first year that we expect full effects because there's a delay with those bait boxes. The bait boxes that were out in the summer of 2017 should have killed the baby ticks on the mice and chipmunks. That will result in fewer nymphal ticks this year. So there's a delay in one of these interventions. The other one is pretty much instantaneous. The major funding comes from the Stephen and Alexander Cohen Foundation, whom Ken mentioned in his talk. We have also received funds from the New York State Legislature. Didi Barrett has been involved in that, Sue Serino as well. And there have been quite a large number of smaller donations to this, and we are actively fundraising right now because the Stephen and Alexander Cohen Foundation grant funds about 2/3 of the required resources to get this project done. And I just want to close by commenting that I think it was Newsweek magazine a couple of years ago did a survey on where they asked people to answer what's the worst job in the world. Tick collecting came out on top, but you'd never know it to see our smiling faces of our crew from 2017, with the one exception of someone who is not very happy to be tick collecting. So with that, I'll stop and we can move to the next segment of our event.
Thank you, Rick. Yes, why don't you, let's have a round of applause for all of our speakers and invite them up here. So we now invite you to come to the mic here if you have any questions of any of our panelists or comments or anything else. You want to do a tap dance, that's okay too. So again, I want to thank all of our panelists. This is really a great range of perspectives on this subject and a lot of expertise. And we'll start with our first question. Please introduce yourself and tell your name and maybe where you live and then where you're directing the question.
Ulster County. Lee Rosenthal, Ulster County. If somebody suspects they have Lyme disease, but they don't have the red rash or any real obvious symptom, what's the best procedure to go through to, what steps to identify and treat?
I think Alison or Ken, go ahead.
Well, it's important to, like anything, connect with a healthcare provider who should take a very careful history and physical examination, and then do appropriate testing, depending on the impression of the physician. If they have a strong enough suspicion that it may be Lyme disease, sometimes it's justified to even treat empirically before the lab data are back, and hope to get laboratory data that will help to rule in the diagnosis. But the problem is that negative tests don't necessarily rule it out.
How do they know if they have a Lyme literate doctor?
Good question. I would say
Sorry.
word of mouth is probably a good way.
And the test you mentioned, is that the Western blot, or is it they're more elaborate when you don't have some of the obvious?
Yeah, there's a range of different kinds of tests that are available. Commonly recommended is what's called two-tier system, where you get a screening test, what's called the Lyme ELISA, and then if that's positive or borderline, then do a Western blot. First of all, there's a lot of variability in the quality of those tests among different labs, number one. Number two, many of us clinicians have found that if you follow the two-tier algorithm, we've seen many patients where the screening test is negative, but the Western blot is either suspicious or sometimes even fully diagnostic. So a lot of us clinicians will kind of shotgun it and do both right at the get-go. And then there's other methods of testing. There's what's called direct detection method testing, where you use a method called PCR, which attempts to detect the actual genetic material of these tick-borne diseases in the person's bodily fluids. The problem is that even the best methods that we have leave a lot to be desired. So the CDC from very early on has said that diagnosing these tick-borne illnesses should be what's called a clinical diagnosis, which means, again, careful history and physical and clinical judgment on the part of the physician, hopefully working in a cooperative way, sort of a consensual way with the patient.
With the what?
With the patient.
With the patient, yeah.
Thank you.
Thank you.
Thank you, Dr. Liegner, Dr. Ostfeld, and Dr. Kaufman. So
Introduce
I have
yourself.
two quick
Jill,
questions.
introduce yourself, please.
Oh, I'm sorry. I'm Jill Auerbach, and I'm from the town of LaGrange. Sorry about that. At any rate, Rick, question for you is, since in some areas there were only 25%, and the best was 40%, are you going to be looking at houses where there were consecutive houses all treated versus those that were not, so that you can make some kind of value judgment based on that?
Yeah, that's a very good observation. We do have, beyond just the entire neighborhood scale, where we want to know how many cases in that neighborhood, how many ticks found on people and on pets, et cetera, how many ticks found by us going
Right.
out into their yards, we can ask more fine-scaled questions, like, is there a relationship between how many ticks are found or the probability of a case as a function of what the nearest neighbors were doing. That's statistically quite possible, and we plan to run those statistics. We have a crack team of really good quantitative folks.
That's great. Do you have many areas where there are clusters where neighbors all had their houses treated?
Yes, we do.
Good.
We have neighbors who, when we were recruiting them, we were doing so by any means necessary, including going door to door. We did a lot of this by phone. When we were doing it by phone, we would have recruited one person in a neighborhood, call the next person on the list, and that person we had just recruited was sitting there in their kitchen saying, hey, I just got a call. I really hope that you'll join me in participating in the project.
Great,
So we
great.
do have clusters of neighbors who are all participating.
I have one other quick question for you. The MET52, I'm wondering if you have figured out what the cost would be per household if it were like 1/3 of an acre to 1/4 of an acre. We know that the TCS bait boxes, that they cost $1,000 for an acre to be covered, which is pretty expensive for the average homeowner. So I'm hoping that the MET52 isn't too expensive. Do you know?
Well, we are buying it at a discount because we're a research organization and a not-for-profit organization. There's a funny thing going on with MET52 right now. The supply is extremely low. We barely got our supply, and people are asking us where they can find it because others want to buy it. It turns out that MET52 appears to be the pest control agent of choice for marijuana growers in California. And so the supply has plunged. Now, if the company that makes it are good business people, they will manufacture more. We're hoping that there's been a lot of attention on both bait boxes and MET52. Manufacturing, the costs of manufacturing go down as the volume goes up. We're hoping that these costs will go down if the interventions are found to be successful, and we're not the only ones asking similar questions, that it would be affordable. And we're hoping that municipalities, government agencies, healthcare agencies might be willing to fundraise for grants so that neighborhoods can deploy this. This is not something we think should be solely the purview of individuals hunkered down in their living rooms worried about the ticks that are going to crawl off their lawn and bite them.
Certainly
But
seems
what
like it
is your
should be.
cost right now? You know, what would you presume?
I don't have an estimate of the
You don't.
per acre cost of
I
the
think we can-
MET52 right now.
I would just like to share something really quickly.
Really quickly, because we've got a
Really
whole bunch
quickly.
of people here.
Subcommittee reports are all online right now. If you want to see them, the next meeting's on the 21st. You can submit questions and comments about it. I don't know who would like to circulate that, but I can give you the website.
Okay,
Okay.
thank you. Thanks very much.
Hi, I'm Julie Rubin, and I represent Three Arrows Cooperative. We're in Putnam Valley, and we own 125 acres collectively. So we would be a perfect research site because we can make a collective decision, and that covers everybody. Because we can't get in on the study, since you've already started, I'm dovetailing with the last question. How could we do this on our own in some way? And I've researched permethrin tubes and putting the cotton in them that then the white-footed mice take out to their nests, and then the other question is, just so I get it off my chest, is there any law of unintended consequences with this fungal spray with MET52? That that's always a question with biological controls.
Mm-hmm.
Right. Yeah, so the first question is a tough one because, what we're doing is akin to an experimental trial for a drug that might cure an illness like cancer, let's say. And there are a lot of people who want to be able to use the experimental drug before it's been demonstrated to be safe and effective. Mm-hmm. And sometimes they are able to get access to that. In our case, we're testing it right now. So it's hard for me to recommend that these products be used at scale until we have results back. And we'll be working like crazy to get these results out as quickly as we can, although we expect a cumulative effect over time. So we don't want to jump the gun. And once you unblind a study, you actually look at which neighborhoods are getting which treatments, you can never go back.
Right.
So I can't say, sure, go ahead and try these things. Of course, you're free to do it, but I can't guarantee that they're going to work until our results come in. That's why doing this work is so important. That's why some of the methods that are effective at killing ticks at a really small scale don't do a thing when they're deployed at a larger scale. So we need to know the answer to this. Then the other question was about unintended consequences. Well, we asked about non-target effects. That's the main one of MET52, and there really weren't any. And it has been tested very thoroughly in terms of toxicity to vertebrate animals like us, and there isn't any. So I think the likelihood is very low.
Nor to any flora.
And it doesn't affect the flora whatsoever.
Okay. And tick tubes, permethrin?
It's a long story. I have a chapter in my book about it. The scientists who found them to be effective own the patent for the product.
Funny how that works.
And I guess that's enough said.
Thank you.
Next.
I'm Susie Fowle from Berkshire County. One question following up on that is if the MET52 has been found not to have unintended consequences, it only targets ticks, is that right? Then why are the pot growers using it as a pesticide or?
So it is used by very high-end growers who have greenhouses because it kills whiteflies and it kills thrips. And we found a very modest and very short-term effect on soil thrips that we have around here. Apparently it works better on thrips that get into greenhouses in Northern California for that cash crop. So it's not as though it has zero effect on any non-target organism, but it has very modest and short-term effects on the ones that we have around here.
Okay. And then also following up on permethrin, you had said that the one really reliable study that was done on
Tick tubes.
no,
Oh,
on
the bifenthrin,
the one
yeah.
that you presented on. So how do we know that permethrin does kill or adversely affect ticks? Has there been a reliable study that at least establishes that?
Yes. So there are small-scale field trials. You take a 5 by 5 yard plot and you spray bifenthrin on it. Maybe you put out no numbers of ticks, or it's a natural tick population, and you can compare that to a plot that you don't spray, and the ticks are reduced. And in that study, the ticks were reduced compared to a water placebo by 63%. So it does a decent job. You can do even better than 63% by spraying with a high-power sprayer, spraying more frequently than just once. So yeah, we know it kills ticks.
Okay, so I think I'm confused that with the terminology. Permethrin is considered a bifenthrin, is that what it's called?
Bifenthrin and permethrin, so they're synthetic pyrethroids. That's a class of insecticides.
Yeah.
Both bifenthrin and permethrin fall into that class. They are chemically slightly
Got it.
different, but they both kill ticks and insects.
Okay.
Thank you.
Sorry
Thank
about
you.
the confusion.
Next.
My name is Elizabeth Schwartz, and I'm from Millbrook, New York. And I'm wondering, is there a toxicity issue with the predators of the mice and the chipmunks from these bait boxes that they're now ingesting the chemicals?
Right. Yes. There is no evidence of any toxicity for predators. So fipronil has been tested with carnivores. Basically, dogs and cats are members of the same taxonomic groups as most of our native predators. And it's a very non-toxic substance on dogs and cats. There are estimates, I can't vouch for them, that a given fox or bobcat would have to eat tens of thousands of mice in a given season in order to get any toxic dose at all.
I'm sure they'd be very happy with tens of thousands of mice.
They'd be happy. They might burst.
Thank you.
Hi, I'm Fred Whitridge from far off Stanfordville, and I have a question for Didi and Ken. I have 4 loved ones who Ken is treating, or has treated. Due to HIPAA reasons, I'll call them Serena, Trina, Marina, and Louisa. They all end in A. And my question was about this CDC fallacy of 2 to 3 weeks of antibiotic treatment. And all 4 of those people that you've treated would be severely debilitated if that's all that they had. I've recently met 3 very close friends who have been on a PICK line for months and months and months with Rocephin and other very heavy-duty drugs. And for Dr. Kaufman, I was disappointed that the link on your website you put up links to the CDC that recommends the 21 days of antibiotics. So my question is, what's going on in terms of the relaxation, Didi, that you mentioned of the regulations so that there can be longer-term treatment, there can be insurance coverage, and we can sort of get after this treatment fallacy, which is the only word I have for it.
Well, I mean, I think you're pointing to the issue around chronic Lyme and does it exist, and this was the legislation that we passed 2 years ago was directly addressing this, and in fact, we've been working on a amendment that would be even more specific because it addressed diagnosis as a key piece of it. So in New York, at this point, a doctor should not be persecuted by the professional agencies for giving multiple rounds of antibiotics if they feel that that is the appropriate treatment, working with the patient and that's in New York State, that is the law, and that's not the case necessarily in every other state. I think the federal government, we will see as a result of this working group that there will be recommendations that are well beyond what the CDC has included. And unfortunately, the CDC, because of its name and stature, is kind of the go-to for way too many people. And it's been a challenge, and to have to go back to, and I do this with my colleagues too, people and say, no, the CDC is just wrong, and to hear figures that they're basically reporting only 10% of what's really out there is problematic. So this is partly why we need kind of an outpouring of of proper information shared by people.
But your legislation, if I understood it, just means that New York isn't going to go pull Ken's license, but it doesn't mandate that insurance companies.
The insurance companies are a whole other issue, which
Right.
we're still working on that front. But yes,
I mean,
but that's important
Is
because
there hope on that front?
on the insurance issue, it's a process. I mean, we have legislation to do. I mean, this is sort of the first step, and part of the challenge is when we have two bodies in New York State right now that operate in with different value systems. So when our House and the Assembly went to introduce legislation, we were focused on the patients, and when the Senate went to introduce legislation, they were focused on the insurance companies. And so we've been working, and we have been working together to try to come up with a study bill to be able to bring both of those issues to bear. But it's a slow process. But I do think that the recognition that doctors should be able to do whatever they want is a big step. I mean, that's not the case in many, I'm sure many of you have experiences of going to doctors where they won't even look if they hear the word Lyme, or if they're pediatricians and they hear the word Lyme, that the doctors won't touch it. And that is because of this history of being harassed around these issues. And I think Ken can talk to this as well.
Yeah, so, I mean, these illnesses are very problematic. They're very difficult. And the mainstay of treatment at the present time are antibiotics of one form or another. And it's good that we have them, and many people have benefited from them, but the fact that sometimes long courses of treatment are necessary, I mean, that's not a great situation.
No, it's not perfect.
So to me, the obvious answer is research. The answer is, okay, you don't like antibiotics long-term? Fine, let's give us an alternative. And that is beginning to happen, as I mentioned. The groups at Northeastern, Stanford, Hopkins, and also Eva Shoppe, University of New Haven, they're really, well, what they're doing right now is, first of all, acknowledge a problem. You might be able to solve it, right? Deny a problem, which has been the approach of the CDC and the insurance industry and the Infectious Diseases Society of America. That has gotten us nowhere. In fact, that has resulted in is a burgeoning epidemic. It's made things much, much worse.
Exploding, I would say, rather than burgeoning.
Yeah. So it's almost like they want an epidemic, I mean, and they have it. So So what these 4 research groups have been doing recently, first of all, to develop a new drug is a very, very arduous process. It takes years and millions of dollars. So what they're doing for starters is they're taking every crazy drug that's in the existing pharmacopoeia. In other words, they already FDA-approved drugs, and they're trying crazy combinations of things that you would never, ever try in vitro, in the test tube, to see what is effective in killing Borrelia. And they're coming up with some really surprising results that nobody would have ever expected in different combinations. So like I said, I'm really very optimistic. We're going to have better methods of treatment. And hopefully the goal, of course, is cure, where you are treated for a finite period of time, and unless you get reinfected, the infection is eradicated. And that should be the goal. And I think a lot of people are working on it.
Thank you.
Thank you.
Thanks. Thank you. Hi.
Hi, I'm Cynthia Carlaw, and I was part of the original long-dragging test in Westchester and Chappaqua in the 80s. Since then, my late husband developed Lyme, and Dr. Abe Levy treated him with Rocephin. My son got meningitis, Lyme-induced meningitis, also Rocephin. I've had it 3 times, and then when the vaccine came out and was fairly shortly withdrawn, I got that, and I haven't had it since. I don't know if it's because of luck or if it's because the vaccination worked, but I feel very lucky. And I would like to know 2 questions. One is, animals have protection for Lyme, for ticks and fleas, but humans have, why can't they make us a collar or a bracelet? And the other one was, that's a question. And are there? You said there are no vaccinations on the horizon, from what I understood. None. They can't bring back the old one.
Yeah, I mean, Lymerix was withdrawn. There's a lot of controversy about that. There's a new vaccine that is currently in clinical trials by a company called Valneva. What the outcome of that will be, how effective and safe it will be, remains to be seen. But at the present time, the mainstay of treatment is personal protection at the present time. And I live right here in Dutchess County. I literally don't step on the grass unless I'm wearing knee-high muck boots that are pre-sprayed with permethrin, because it's very easy to pick up a tick. So right now, personal protection for those people at 3 Arrows, that's what I would rely on right now, is personal protection. And you have to become really obsessive compulsive for that to work.
So does the vaccination work that I had? And also, the first map that you showed of the United States with the preponderance of darkness in the Northeast, I thought it showed Massachusetts to be a light spot.
You know why there's a light spot?
Because they don't report it?
Exactly. There's been no funding for reporting. Massachusetts has a tremendous problem with Lyme. Yeah, it's a real anomaly.
And no answer about the dog collar for people?
I'll speak to that a little bit. So it's really interesting. I was doing a lecture for senior students in an AP Environmental Studies class, and one of them asked me that same question, and I just thought that was such a great vehicle for critical thinking and young minds developing. So, what are the reasons why no company would choose to try to market a tick collar for human beings? And once we kind of think about it that way, they started coming up with a lot of hypotheses for why we would have trouble bringing something like that to the market. So certainly there would be some people that would do that, but I think that the compliance with wearing something 24/7 like the Seresto collar that I hawk for people to use on their dogs, we might have an issue with that. The other thing that you see that is different in animals from people, going back to my days as a veterinarian, is that there certainly is a lot of regulation in bringing drugs to market, but not as much as in people. So we can be a little bit more free in trying things, and sometimes that leads to a little bit of Wild West stuff, which can be disturbing on the other end as well. For instance, the vaccine that we use in dogs is not labeled for horses, but we were using that off-label. and it has been shown to be effective, but that's an off-label use. But you can't muck around like that with people. That doesn't happen. So animals have a shorter lifespan than people. So some things that we might see with toxicity won't show up in an animal that has a much shorter lifespan because they're not being exposed to low levels of something for a long period of time. So it would be hard for me to imagine how somebody could design a clinical trial to show that a person wearing an impregnated collar 24/7 would be safe.
Would you have to wear it 24/7,
I
or could
wasn't
you just wear it
thinking of a
outside?
collar. I was actually thinking more in terms of something that you could put on your clothing
Right. Well,
outdoors.
well, we have that.
that's
We
for-
have
what
permethrin,
permethrin does,
and,
that's
and
what-
I run around and I do the permethrin dance to encourage people to use
What
that.
about diatomaceous earth that gets into the respiratory system of crawling creatures?
So putting diatomaceous earth on your body?
No,
okay.
on your lawn, around your garden.
Oh, that's a
Okay.
good question.
It's one of the long list of things that have been found to be moderately successful in small-scale trials. But whether it actually protects your health and at what scale you have to apply it to protect human health, we don't know.
Okay.
I think we have one more question, and then hopefully our panel will be able to stay around and help. Okay, thank you.
Lawrence Miller from Rhinebeck. Rick, several years ago you came to the Star Library and gave a really terrific presentation, and it's very encouraging to see what you and your colleagues have done since that time. It was a good 3, 4, maybe 5 years ago, so I applaud that and thank you. Okay, this is designed to decrease what I call my freak out factor. What % of ticks are actually infected with and carry Borrelia? In other words, not every single tick we find on us is going to, I mean, we have to act as if they do, I get that, but.
So the long-term average, 25 years of data,
Yeah.
tens of thousands of ticks that we happily crush in the laboratory and test for their
Is that
infection.
enough? Actually, is that a big enough sample?
Well, we keep getting the same number even when we do more. So it's about 30% of the nymphs.
30% of the nymphs
So you've
carry
got a
it.
1 in 3 chance if you
Okay.
get bitten by a nymph, if it feeds to repletion,
Right.
of getting exposed. For adults, it's more like 65, 70%, but they're much easier to detect and pull off, and they're active typically at a time of year where we spend less time outdoors. So it's really the nymphs are the culprit. 1 in 3.
All right, that's a little placated. All right, thanks.
Thank you. Well, thank you to our panel. This was